Marhaba, bienvenue, benvindo, welcome to the first International Conference on Public Health in Africa. This historic conference comes at a critical moment for the continent and the world. While COVID-19 has had a devastating impact on health and economic development, the pandemic has also offered important lessons for how to strengthen preparedness against future health crises and better address current challenges. Through 3 days of engaging presentations and discussions, CPHIA will provide insights into the latest in COVID-19 research and learnings and help usher in a new era for strengthened collaboration on the continent. With over 10,000 registrants from around the world, we can together use this moment to build a new public health order for Africa and achieve the Africa we want. On behalf of the African Union, Africa Centers for Disease Control and Prevention, and the co-chairs of CPHIA 2021, thank you for joining us.
Jambo from Nairobi, and as we say in Swahili, karibuni, welcome. Welcome to the first International Conference on Public Health in Africa. I'm Zain Verji. CPHIA 2021, hosted by the African Union and the Africa Centers for Disease Control and Prevention, is the very first of its kind. This is a 3-day event that will create such a unique platform for all participants to collaborate on research, on innovation, and public health across the continent. In the coming sessions and days, you are going to hear from an impressive lineup of speakers who will address the key health challenges facing Africa and share the latest insights, the research, and the learnings from the past 2 years of fighting the COVID-19 pandemic. We will look ahead, far ahead, and discuss how we come together to establish a new public health order and build a more resilient Africa. Of course, this conference could not be happening at a more important moment as the world just begins to grapple with the emergence of Omicron. Scientists from South Africa and Botswana have shown extraordinary leadership in rapidly providing world-class research. Unfortunately, that research has not led to evidence-based policies. It is clear that we must urgently elevate the innovative research coming out of Africa. And that is exactly what will be happening during this conference. Before we get into the scientific presentations, we have the honor of hearing from several distinguished African leaders. All are at the forefront of the fight against COVID-19 and have committed to improving public health on the continent. It is now my enormous pleasure to announce our first speaker, His Excellency Felix Antoine Tshisekedi Tshilombo, the President of the Democratic Republic of Congo and the Chairperson of the African Union. President Tshisekedi has provided incredible leadership in launching the Partnerships for African Vaccine Manufacturing earlier this year. This is a joint AU and Africa CDC endeavor designed to expand vaccine manufacturing on the continent, a key pillar of the new public health order for Africa. Your Excellency, welcome. As we wait for His Excellency, I would like to thank everybody for joining us here. And, these technical hiccups that we've gotten quite used to now, right? So apologies for that. We'll get back to His Excellency in just a moment. In the meantime, it's my great privilege also now to introduce His Excellency Paul Kagame, the President of Rwanda and the African Union Champion for Domestic Health Financing. And as champion, President Kagame has called for greater investments in national health systems across the continent, which would really increase their resilience in the face of new crises and improve health outcomes. Welcome, President Kagame.
Well, thank you, Moderator. Excellency President Felix Antoine Tshisekedi, Chairperson of the African Union, Excellency Musa Faki Mahamat, Chairperson of the African Union Commission, Dr. John Nkenga Song, Director of Africa CDC, Dr. Mashidiso Moretti, WHO Regional Director for Africa, conference co-chairs, distinguished ladies and gentlemen. The inaugural conference on public health in Africa is an expression of our continent's commitment to forging a new public health order for Africa. I commend the African Union Commission, led by Chairperson Musa Faki, as well as African CDC under the leadership of John Nkenga Song, for not allowing this moment to pass us by without clearly articulating Africa's needs and ambitions. The new public health order has 4 components where we have already made good progress, but need to do much more and do so faster. First, we must continue to build the capabilities and professionalism of our continental health bodies. Africa CDC has provided clear leadership throughout the pandemic and helped many of our countries access tests, protective equipment, and vaccines. Strive Masiyiwa has also made a critical contribution. I wanted to thank him for that. The African Medicines Agency, AMA, has now come into force, and once established, it will allow Africa to provide emergency use authorization for vaccines and pharmaceuticals without intermediaries. It is important to speed up the implementation of the AMA and to see more member states ratify its statute. Second, there needs to be a renewed commitment by governments and national parliaments to increase domestic financing for health in Africa. This has been a priority of the African Union for several years, but progress has not been fast enough. We cannot continue to rely on external funding for something so important to our future. Third, and closely linked to this, is the need to invest much more in national health systems. The ability to implement critical health programs, including regular mass vaccination campaigns, depends on the quality of national health services and the trust that the public has in them. And finally, let's continue to work together to implement the Partnership for African Vaccine Manufacturing. This historic initiative, launched in April this year by our chairperson, President Tshisekedi, has already catalyzed new vaccine manufacturing initiatives in various African countries. Building manufacturing capacity is the only way to ensure that Africa does not remain at the back of the queue for life-saving medicines. The uncertainty around the new Omicron variant proves that the pandemic is far from over. We must remain vigilant and act with a sense of urgency and purpose, both as a continent and together with our partners around the world. I wish you a successful conference and thank you for giving me this time and your kind attention.
The pandemic is far from over. We need to do more and be faster. Domestic financing for health is a priority. Thank you, President Kagame, for your strong and important words and your continual commitment, adding too that we cannot continue to rely on external funding for our futures. We need to invest much more in our own national health systems, including President Kagame saying that regular mass vaccination campaigns were essential and that it was important to have the trust of our populations. And of course, a core part of all of this, President Kagame underscoring that we must build our own manufacturing capability. Thank you, Your Excellency. Now, unfortunately, our next speaker, His Excellency Cyril Ramaphosa, President of the Republic of South Africa, is unable to join us today, but he does send his best wishes, including for the success of this conference. I would now like to introduce His Excellency Moussa Faki Mahamat, the chairperson of the Commission of the African Union. An advocate for the continent on the world stage, Mr. Mahamat has worked closely with partners on COVID-19's response and make sure that there is much greater coordination at the global level. Your Excellency.
Thank you very much. Excellencies, Head of State and Government, ladies and gentlemen, dear friends. On behalf of the African Union Commission, I would like to welcome all of you joining us from across the African continent and around the world. The inaugural Conference on Public Health in Africa is happening at an important moment in history, and I am honored to speak with you today about how we can work together to achieve public health security in Africa. I want to start by thanking all African Union member states and leaders, as well as the African Centers for Disease Control and Prevention, Africa CDC, under the leadership of Dr. John Kengasong, for their extraordinary leadership in combating the COVID-19 pandemic over the past 2 years. The African continent has not been spared from the devastating effects due to COVID-19. Many have fallen thick, pushing our health systems to their limits. The economic damage caused by COVID-19 has left many jobless, hungry, and vulnerable. And the effects of the global economy on health security and on sustainable development cannot be overstated. Despite this, we have great hopes for the future. COVID-19 has also created a historic opportunity to build a new public health order that can effectively guard against future health crises. And this inaugural conference on public health in Africa is a first step in making this a reality. The Africa CDC and African Union have convened this conference to provide a unique platform that brings together the best and brightest minds in public health in Africa together in service of this larger goal. Over the coming days, we will hear experts from across the continent and beyond within our topics that are vital to Africa's continued prosperity and improved health status. We will learn about the epidemiology, prevention and management of COVID-19, as well as other infectious diseases threatening our continent. We will hear about the state of COVID-19 vaccination in Africa and how we might prepare for what's next. We will discuss what an equitable approach to health systems might look like and how we can leverage the best available evidence to fulfill this goal. We will bring together the whole of society to highlight the critical roles that the private sector, civil society, and communities play in building this brighter future. Together, we will create a new benchmark for collective efforts and participation as we advance public health and practice, education, training, and research in Africa for Africa. Lastly, to achieve this new public health order, we must strengthen our partnerships and collaborations to chart a course for our own future, a future of self-resilience. I would like to assure you today that African Union Commission stands firm in our resolve to bolster manufacturing capacity for vaccines, diagnostic and therapeutics, to build resilient health systems capable of detecting future health threats, and to build financing mechanisms that allow member states to respond efficiently and effectively to the health needs of the continent. We learned best by looking back so that we can move forward. Thank you all for reflecting with us over the coming days as we continue in this fight against one of the deadliest pandemics of our time. We look forward to engaging you all as we collectively chart the way forward for Africa. I thank you for your attention.
Merci.
COVID-19 has impacted health systems in a very fundamental way. When this pandemic hit us, we had no access to diagnostics. We still have very limited testing capacity. As a continent of 1.2 billion people, we have limited access to vaccines. We have to begin to decrease our dependency for health security needs. But of course, do that in action-oriented, respectful partnerships that constitute what we are calling a new public health order for the continent.
While the world is vaccinated at very high level, Africa is lagging way behind. So this is mainly due to the fact that we have very limited capacity when it comes to manufacturing a vaccine.
We can today say the continent wants to get to a 60% target of vaccine manufacturing in 2040. So it's not a lofty goal, it's a goal that can be achieved.
Because of this terrible pandemic, an opportunity has been created to fundamentally change the pharmaceutical production landscape on our continent.
Building local capacities involves various partnerships. And here I have to commend Johnson & Johnson. They have partnered with Aspen, Africa's largest pharmaceutical manufacturer, which will ultimately give the continent greater independence and autonomy, and will give the continent its own COVID vaccine.
Afrigen is appointed as the first hub for mRNA technology transfer and training, not only for COVID-19, but for other vaccines.
As a vaccine production company based in South Africa, we've also sought to establish technology transfer partnerships for vaccine production, COVID-19 vaccine production. mRNA is the new technology kid on the block with plenty of promise into the future.
One One of the specificity of our vaccine manufacturing project is that it has been built as a platform where we're leveraging new technology, and that allows us to be flexible in terms of technology and in terms of quantity, and be ready for the future.
For the first time in Egypt, Egypt is building their own vaccine technology, and we finished successfully with the preclinical studies, and we have started the first stage clinical trial for the Egyptian vaccine Covivax, and delighted to share this new experience with our sisters and brothers in Africa.
Commitment to our own health security. It is no longer a theory or a speculation, it is reality.
African leaders, researchers, and scientists have shown tenacity and made real progress in the face of so many challenges.
This is a huge turning point, both in terms of the political commitment, mobilizing resources, and also mobilizing all the stakeholders to get this capability built on the continent.
This window will not stay open forever. Now is the time to act decisively and quickly together as Africa and also globally.
As we've learned during the pandemic, expanding Africa's capacity to manufacture vaccines is an urgent priority for achieving greater global equity in access to health products. It's now my great pleasure to introduce Dr. Mashidiso Moretti, the Regional Director for the World Health Organization's Office for Africa. Dr. Moretti is the first woman to have been elected into her role, which she assumed in 2015. Since then, her work has focused very heavily on cultivating some strong partnerships on the continent. Dr. Moretti.
Thank you very much, Madam Moderator. Your Excellency, President Paul Kagame of Rwanda. I'd also like to greet and pay my respects to President Tshisekedi of the DRC, the Chair of the African Union, and in his absence, to President Cyril Ramaphosa, who has played such a fundamental role in the work we're collectively doing on the pandemic, a goal that we collectively share. This gathering couldn't be more timely, coming at the end of 2 years battling the COVID-19 pandemic, with the Omicron variant having triggered travel bans against Southern African countries by nations across the world. In addition to the lives lost, the impact on education, other development sectors, Africa's economies already had a lot lost from the pandemic, and this can only exacerbate them. And this will continue if we fail to achieve what we are looking for collectively, that is strengthening the public health capacities in African countries. We cannot afford the economic toll of pandemics on our continent. The inequities in access to key tools required for the pandemic response, which exposed our extreme dependence on manufacturers outside the continent, it's already been said, cannot prevail going into the future. We in WHO have very much appreciated the mobilization of concrete responses by Africa's political leaders, coordinated by the African Union and supported by the Africa CDC. And I'd like to express our sincere congratulations for this unprecedented, action-oriented response, which is building on the progress and achievements that have already been made in Africa in addressing, controlling other diseases, including polio, of which the wild variant was eradicated, HIV, reducing the toll of neglected tropical diseases, as well as starting to address the non-communicable diseases which are rising fast on the continent. And as WHO, we've been pleased to play a key role in guiding and supporting countries, as we have in supporting the COVID-19 response, coordinating continental action together with the Africa CDC. We remain committed to giving our countries a voice in multilateral negotiations and interactions on the international stage as well, and in supporting the facilitation of partnerships that are based on equity, mutual respect, and mutual accountability. So creating a new public health order on our continent requires, first and foremost, and I would like to echo His Excellency President Kagame, investment in creating health systems that are resilient, with not only epidemic preparedness and response capabilities, but also the capacity to continue the uninterrupted delivery of day-to-day and chronic healthcare. That implies that the investments must be made in such a way that we have cross-fertility between preparedness, pandemic response, and surveillance, as well as health service delivery, and very important, what happens at the community level. In 2001, the African Union's countries committed to allocating 15% of their government budgets to health. And we feel a recommitment to this goal would avert what we are seeing, the current stagnation, and in some cases, a decrease in overall health spending in the continent. And we know to what degree the impact of the pandemic on our economies might exacerbate this further. So building the human resource capacity, starting at the community level and right up to institutional levels, is the next important point. We've seen that community health workers have been pivotal in key response activities, not only to this pandemic, but also to maintaining primary health care generally. Research, innovation, and local manufacturing are central to a swift and effective health response. We currently import over 90% of our medical requirements, and we would like to congratulate those leaders, including President Kagame, because he's present, that have taken such rapid action to make sure that the manufacturing capacity moves to countries in the region, as well as our dependence on international supplies. The pandemic response also illustrated the need for strong connection and linkages between human resource capacities, communities, national public health institutions, scientists, innovators, financing institutions, and international or multilateral institutions and platforms. At the continental level, a strong Africa CDC will be needed to build on the great start that it has made under Kankengasong's leadership. And I was very glad as the WHO Regional Director to be able to support this by seconding a staff member who served as John's first deputy. Indeed, in addition to increasing self-reliance, Africa needs to better take its place in influencing decisions and actions in the global multilateral space. And we in WHO in the region are committed to collaborating to support this, working with the African Union Commission and the Africa CDC. The resilience of our communities and the critical role they have to play in the control and elimination of diseases in Africa has been amply demonstrated. And moving forward, we recommend that strategies should harness these examples of individual and community components. And then finally, data and information systems that let us know what progress is being made, what progress still has to be made, and using digital technology will be key going forward. And our public healthcare strategies must take advantage of this rapid evolution. The regional office of WHO in Africa took the lead in establishing global databases of more than 2,000 technological innovations deployed during the pandemic response and vaccine delivery. And these are available for use by our countries as well as by our partner, the Africa CDC and others. In closing, I'd like to commend you all for having convened this conference, for the absolute determination to move Africa towards self-determination, a better public health order, and we'd like to assure you that WHO will accompany and support this process all the way. Thank you very much.
Dr. Moretti, thank you very much for those words and for highlighting some key issues that are going to be important for framing this conference, and speaking also on behalf of the World Health Organization and acknowledging and appreciating the mobilization of African leaders over the past 2 years, whose work has been, as you say, action-oriented and building on progress that has been made. Among some of the key highlights of what Dr. Moretti said, we've got to have investment in health systems, not just to manage crises and responses, which is critical, but also to maintain general health services and delivery as well. Also to maintain continuous rapid action as part of the manufacturing efforts on this continent. And lastly, Dr. Moretti highlighted the importance of data and information systems and the digital ecosystem as being essential for the continent in going forward. Asante sana. It's now my honor to introduce Professor Onyes Binagwaho, the Vice Chancellor of the University of Global Health Equity and CPHIA 2021 Conference Co-Chair. Formerly the Minister of Health for Rwanda, Professor Binagwaho is a strong advocate for health equity, a commitment that she has carried over to conversations around COVID-19 response and preparations for future pandemics. Professor.
Thank you very much. Your Excellency, President of the Democratic Republic of Congo and Chairperson of the African Union, Félix Antoine Tshisekedi Chilombo, Your Excellency, President of the Republic of Rwanda and African Union Champion for Domestic Health Financing, Paul Kagame, Your Excellency, Chairperson of the Commission of the African Union, Moussa Faki Mohamed, Regional Director of Africa World Health Organization, Dr. Moretti, my co-chair of the International Conference on Public Health in Africa 2021 and director of the global programs at the Susan Thompson Buffett Foundation, Professor Senait Fiseha, the director of the African CDC, Dr. John Gengasong, distinguished guests, colleagues, friends, and participants to this conference. It is my distinct honor to add with emotion, my words of welcome to all of you at this first International Conference on Public Health in Africa, which I have the great pleasure to chairing along with Professor Senait Fiseha. The ability to follow science and to communicate the truth to the public is central to successful responses to any health challenges. In light of truth-telling, this high-level convening has to reflect on the role of evidence-based policies in the pandemic and how the spread of misinformation has been a major challenge and a determinant of COVID-19 mortality. Communicating accurate health information and improving accountability must be priorities in all our work. With the development of vaccine, we have learned how collaborative research speeds the capacity to save lives. We have also seen how a non-collaborative approach has aided our response. The current challenge have demonstrated also more than ever the need of building research capacity in Africa. This pandemic has also shown us once again how regional collaboration can make an extraordinary impact on our development and progress in Africa. And that is why I'm so proud of the exemplary role that Africa CDC has played in uniting the continent and harmonizing our response to COVID. We had great hope with the rapid development of COVID-19 vaccines and the ambitious COVAX commitment. But as my president, His Excellency Paul Kagame said, we quickly learned that local manufacturing of medical products is no longer just an option. It is essential to our development, our future, our survival in Africa. So we must commit to never again allowing ourselves to be relegated systematically to the end of the list for procuring desperately needed life-saving tools and medicine. And this happened even when we were willing to pay in advance for this product. We were also subjected, yet again, to narrative portrayals of Africa's capacity to respond to health threats and to the COVID-19 pandemic in particular? Remember, in 2019, the Global Health Security Index predicted that in the event of a global pandemic, the US and Europe will be the most prepared and have only slight disruption, while African countries will face a collapse of the health sectors and over 10 million deaths. These predictions were clearly way off. So let us all approach our work with determination and strong commitment to science, but also with humility, curiosity, and openness. These are just a few of the reasons why this conference is so crucial. COVID-19 is simply a dress rehearsal. We still have a long way to go to build the Africa we want. African scientists, clinicians, policymakers, healthcare workers, health science educators, and civil society, we all come together over the next few days in this historic meeting. We will share scientific data, take stock of our progress, and determine how we can build public health systems that provide all Africans with the bright future we all deserve. I look forward to the exciting discussions and outcomes over the next few days. And I thank the scientific committee who did a great job in putting together all the program of this conference. Thank you for the honor and the opportunity to serve as co-chair of this extraordinary scientific meeting. Thank you for listening to me.
COVID-19 is simply a dress rehearsal. Professor, that is a sobering thought and some powerful words you're leaving us with there, and therefore, once again, highlighting the importance of being able to manufacture our own vaccine products, and as you say, how essential it is for the future of Africa, as is collaborative research, as well as building research capacity overall on the continent. Thank you so much. I'm very thrilled now to introduce Professor CPHIA-2021, the Director of Global Programs at the Susan Thompson Buffett Foundation and Clinical Professor of Obstetrics and Gynecology at the University of Michigan Medical School. She is also a CPHIA-2021 Conference Co-Chair. Professor CPHIA is a global leader in expanding access to reproductive health services and advocating for women's health and reproductive rights. I'm also a great admirer and a fan, and she is truly a modern day superwoman, and I'm very proud to call her my friend. Professor CPHIA.
Thank you, Zain, for that very kind introduction. Your Excellency, President Paul Kagame, President of the Republic of Rwanda, my new home, Chairperson of NEPAD and AU Chairperson for Health Financing, Excellency President Felix Antoine Tshisekedi, Chairperson of the African Union, President Cyril Ramaphosa, President of Republic of South Africa, Excellency Moussa Faki Mahamat, Chairperson of the African Union Commission, Excellency Dr. Shidi Moretti, my friend, who is the Regional Director of WHO Afro, Dr. John Nkenga Song, who's been leading our continental effort in tackling the COVID-19 pandemic and the Director of Africa CDC, and my esteemed co-chair, the first conference on public health on Africa, Professor Agnes Binagao, all protocols observed. The last 2 years have been extraordinarily challenging. Shameful levels of vaccine nationalism, hoarding, and inequity have left far too many countries in Africa vulnerable. We have seen calls for global solidarity fall on deaf ears. This is, of course, not the first time we've witnessed this in actions, but it is an acute reminder that the global health system is not set up to deliver for our countries and our people. But that is not why we are here all today. We are here because this crisis has spurred unprecedented solidarity among African countries, leaders, scientists, researchers. We are here because they have created momentum around a new public health order for the continent. There is no shortage of milestones achieved in this last 2 years for our continent under most challenging conditions. The African Union and key partners built the African Medical Supplies Platform to facilitate more efficient procurement of key medical commodities, vaccines, therapeutics, and diagnostics. The African Pathogen Genomic Initiative was created to bolster disease surveillance across borders. We have proven that the continent can produce safe and effective vaccines, and Senegal, Rwanda, and South Africa are developing mRNA vaccine manufacturing capacity critical to the fight against COVID and whatever the next pandemic may bring. The African Medicines Agency was ratified, which is a key step in setting the stage for regulatory harmonization across the continent and bringing new drugs and vaccines to our people faster and more efficiently. And to support trade and exchange of goods across borders, we now have the African Continental Free Trade Agreement. Of course, none of this happened by accident. It's the result of investments countries in this continent have made in public health and science, visionary leadership at the highest level of government, the African Union, African CDC, and so many other continental and global partners, and the tireless work of so many of you around this virtual table. These are the building blocks of the new public health order, which will change the face of health on this continent, but we need to do much more. We need to seize this moment, this momentum to push boundaries. We need to continue to invest in our greatest resources that are our people. This includes strengthening teaching facilities in national and subnational institutions to train doctors, researchers, and frontline health workers. It also includes supporting the broader workforce to deliver on the vision: epidemiologists and data scientists, manufacturing, distribution, logistics, and supply chain experts, scientists and innovators, and so many others. And most importantly, it's an opportunity to continue to build towards the future of public health on this continent, one that is firmly rooted in equity, dignity, and justice for all Africans. It has been an enormous opportunity and privilege and honor to work with so many scientists across this continent, along with my co-chair, Professor Agnes Benagawa, in shaping the program of this conference. We wish all of us a very successful convening, and we look forward to learning from the deliberations of this team to really inform the next phase of our public health fight. Thank you.
We must seize this moment. We must seize this momentum and push boundaries and invest in our people to deliver on our vision that is rooted in equity, dignity, and justice. Professor Fiseha, thank you so much for your strong and poignant words, especially saying how important it is for this conference to highlight the incredible science in Africa. Professor Fiseha adding too that we need to channel new resources into healthcare and build new collaborations to support the vision that exists in order to reach the most vulnerable. Please welcome me now in joining our final speaker and listening to his words, Dr. John Nkengasong, the director of the Africa CDC. He has been such a crucial voice in Africa's efforts against COVID-19. Dr. Nkengasong has worked tirelessly around the clock for 2 years to coordinate a continental response against this global threat. I'm so pleased to welcome Dr. Nkengasong to share some thoughts.
Thank you. Thank you so much, Zen. And Excellency Felix Tshisekedi, President of the Democratic Republic of Congo and the Chair of the African Union, His Excellency Paul Kagame, the President of the Republic of Rwanda, His Excellency Musa Faki Mohamed, the Chairperson of the African Union Commission, Dr. Chidi Moretti, Regional Director of the WHO Afro, Professor Senait Fiseha and Professor Agnes Binawayo, who are the co-chairs of this conference, and I'm very privileged to call them my dear sisters. And thank you so much for what you've done in organizing this conference over the last 2 years. Distinguished colleagues, friends, ladies and gentlemen, it is a great pleasure to join this platform today for the inaugural conference of the Public Health in Africa, what we commonly call CPHIA 2021. Let me just take this opportunity to announce that as of this moment, 15,515 participants have registered on this platform. I'll start on that note to say that this is an unprecedented moment for all of us. This is a historic moment because we've all collectively seen how the threats of a disease can undermine our economic security, undermine our health security, and undermine our national security. Maybe, and just maybe, the Ebola outbreak in 2014, 2016 was a call to action that something bigger was to come. And just maybe that COVID-19 is that call to action that Ebola signaled us. And who knows, it may just be as well that COVID-19 is pointing us to a direction that something even bigger will come. So we must be prepared and take our destiny, our health security destiny into our hands. So I'm very pleased to see the momentum and the extraordinary leadership, political leadership over the last 2 years in managing this pandemic. His Excellency Musa Faki Mohammed, I cannot thank you enough for all the support to Africa CDC over the last 2 years in this pandemic. Several times in your office, you've called us to action and you said, look, we have to react with speed and timeliness. And you actually equate that to responding to a military crisis. So for that, we will be eternally indebted to you. I'd like to echo what others have said with respect to the new public health order, that we have to take our destiny into our hands such that we fight the next pandemic in a way that is unparalleled to the way we are fighting this pandemic. And I'm very convinced that we will do that, given the mobilization, commitments, and investments that are currently going on. I call on all the 15,000 registrants on this conference to actually participate with vigor because the quality and content of this meeting is very rich. You'll find out for yourself so many sessions that are bringing young scientists together with the experienced ones and policymakers to interact on this platform. So do not miss this opportunity. I truly look forward to an exciting encounter such that we come out of this with a clear definition of the pathway to harness the potentials, the tremendous potentials that exist on our continent to advance public health on the continent, which we now know is a critical factor for our development, our security, and human security as well. Thank you so much for the opportunity.
We must be prepared and take our destiny in our hands. Dr. John Nkengasong, thank you so much for your words and for all your work. It's now my pleasure to introduce an original song created just for this conference, featuring some really amazing up-and-coming artists from the continent. And by the way, you know that these are the talent that can carry important health messages around the continent. Please watch.
Our story is still being written. We decide where it goes. The time that we have been given is more precious than we know. Great things arise when we gather our minds for change. It's the little things that matter. Remember to wash your hands. Remember your every effort contributes to the bigger plan. We're duty bound to ensure that our world is safe. So will you walk with me? Let's travel this path together. We're doing all we can to see that it gets better. Stand up for the future, for Mama Africa. Stand up for her people. Stand up for
for diseases is a heavy burden to bear. Let us support our scientists, believe in their ideas. Rise up and be the change that you want to see. We know the land that we live in, so we should take the lead. Finding the
at this particular moment in history. My name is Magda Robalo Correa Silva. I am the High Commissioner for COVID-19 in Guinea-Bissau and one of your moderators of the first session of the Conference on Public Health in Africa. It is a great pleasure to welcome you all to this first session of this inaugural and historic conference. This is indeed an unprecedented, bold momentum to reset Africa's public health order. This session will discuss the epidemiology of SARS-CoV-2, virology, prevention and clinical management, and the discussions will be led by 4 eminent experts. I'm joined by Dr. Trevor Crowell from the US Military HIV Research Program as co-moderator today. And without further ado, I will hand over the floor to him so that he introduces himself and introduce our first speaker. Over to you, Trevor.
Thank you so much. And indeed, it's exciting and a pleasure to be a part of this opening plenary session for this great conference, having just heard from a wonderful group of speakers at the opening session. And now it is indeed my honor to introduce Dr. John Nkengasong, Director of the Africa CDC, who will share with us an update on the state of COVID-19 in Africa. Dr. Nkengasong, thank you very much for joining us.
Thank you. Thank you so much for the introduction and for the opportunity to provide you the state of the COVID-19 in Africa at this inaugural conference for the Conference in Public Health in Africa, where, as I stated earlier, over 15,000 participants have registered over the last couple of weeks. So in the next 15 minutes allocated to me, I'll do essentially 2 things. I'll review for you the epidemiological situation of the COVID in Africa, but focus essentially on some of the lessons that we have learned, at least from the perspective where we sit on the pandemic and response in Africa, and then conclude on the way forward, what we see this pandemic going in terms of preparing for it, and then in terms of preparing for the next one. So let me start with the epidemiologic situation. This is a very interesting picture here. It shows you how the COVID-19 pandemic, or the SARS-CoV-2, which is the virus that causes the COVID-19 disease, has spread since it was identified. And I would like to walk you briefly from left top panel to the bottom right-hand corner. If you look at the graph carefully, or the picture carefully, in January 20th, only 4 countries, mainly China and surrounding countries, have reported the first cases of the SARS-CoV-2. By February 15, 28 countries have reported it. And note that on the continent of Africa, only Egypt on the 15th of February had reported cases. By March the 1st, 66 countries, including a few more in Africa, had reported the cases of the COVID-19. But 2 months later, to be very specific, on March 20th, 165 countries, including many countries in Africa, had reported the presence of this virus. Just within 2 months, the whole world had identified this virus in their respective countries. That speaks to the connectivity that we are as humanity, that we are more connected than we thought we are. We are more vulnerable than we thought we are, and inequalities that we shall be discussing, or inequities that we shall be discussing during this pandemic, stood out very clearly in the last couple of months. In Africa, to be very specific, as we speak, as of today, about 9 million cases have been reported, officially reported, underlined officially reported, of which about 213,000 have died. If you look at the curve on your right-hand side, it shows you the 7 days daily moving average. And the red line there is a summary of that over the last, the period of this crisis we are dealing with. And underneath that red line are the different colors, and they represent the 5 geographic regions of the African Union. that is Central Africa, East Africa, North, Southern, and Western Africa. But I also like to point out two things here, that we've gone through three waves of this, or 3 waves of this pandemic. The first wave was last year around July, August, where as a continent, we were officially reporting about 18,000 cases per day. The second wave was towards the December-January period, where we were reporting about 32,000 cases per day. And then the third wave occurred around July, August of this year, and we were reporting about 45,000 cases a day. And it just looks like we are actually moving into the fourth wave, as you can see, and the very tail end of this graph with a triangle there, and especially driven by Omicron. If I just expand on that a little bit, and we focus in Southern Africa, and I'm sure that Professor Karim will expand on this. The graph you see here points you to where Omicron was first reported in South Africa and Southern Africa. And at that time, we're going through a very low transmission season, where about 490 cases of COVID were being reported. But as we speak today, evidence and data suggest that we are recording about 15,000 cases in the Southern African region. So clearly, that region is moving towards aggressively towards the fourth wave. Similarly, in West Africa, we see that that region is moving towards the fourth wave. In Central Africa and East Africa, similarly, and Northern Africa. I will not expand into that extensively because we published the details of the first and second wave in the Lancet paper, and we clearly indicated that each time we have a wave, it is more severe than the previous wave. For example, during the third wave of this pandemic in Africa, about 80,000 people died, representing about 40% of all deaths just during the third wave that occurred around August and September of this year. We continue to believe that the COVID-19 situation in Africa is a puzzle, and we need more data to understand the determinants of COVID across the continent. We published some of these thoughts and reflections in a perspective we wrote in Science at the start of this year. And we argue again subsequently that we needed more data, more serologic data, and especially laboratory data to support this assumption. And we have now conducted, as Africa CDC, a large case study in 5 member states where we sampled about 31,000 participants from Uganda, Togo, Ethiopia, Zimbabwe, and Sierra Leone. And we asked a simple question that how many people that we are sampling have actually been exposed to or are currently infected with the COVID-19 virus. And this sample size is indicated here. If I just take Uganda, for example, we sampled about 5,500 individuals very systematically using the most rigorous sampling techniques. And you know that Uganda is currently reporting that a cumulative number of about 40,000 cases. But this estimate that we found, that is 20%, we found that 20% of the 5,500 people that we sampled had actually been exposed to the COVID-19 virus or were currently infected with. So if you factor that number into the equation, it suggests that clearly that about 3.2 million people actually have been exposed to or infected in Uganda. That means that, the numbers that we're currently reporting represents about 80 times less the number that are actually the case. So similarly in Togo, we found that 15% of the population we sampled, that is 6,000 people, had actually been exposed to the virus or were currently infected with the virus. And that represents, if we factor that into the population, it represents about 1.4 million people that have actually been infected. And that represents about 106 times more cases that have been reported. Then systematically, you can look into Ethiopia, Zimbabwe, and Sierra Leone. So I think this is the power of data that we need to continue to enhance and fashion our ability to collect data so that we can actually know the true picture of what it is that we are going through on the continent. So let me now focus on the lessons, some of the key lessons that we've learned from this pandemic. When I reflect back on the last 24 months that we've gone through this pandemic, there are what I call the 5 Ps of this pandemic. that we need to know our pathogen, we need to know our population, we need to know the policies, develop the right policies and the right politics, and then understand the right partnerships. So those are the 5 Ps that I would like to comment on. But here are 7 lessons that inform those 5 Ps. First of all, and if you don't pay attention to the rest of my presentation, you can take away these 7 messages. That one is that the strong political leadership of the continent has been remarkable. And you saw an expression of that in the session that just passed with President Kagame, Chairperson Moussa Faki, and other head of states who had contributed. And they have been doing so over the course of this pandemic. The second lesson we learned from this pandemic in the spirit of the 5 P is the critical role of the National Public Health Institutes, and it speaks to a new public health order. The third lesson that I'll comment on is the power of regionalism, that as a continent, if coordinated appropriately with the right leadership, political leadership, we can take our own destiny into our hands. Fourthly is that the continent needs to focus on manufacturing what we call the health security commodities, and then invest in workforce development. Respectful and action-oriented partnership is so important, and that pandemics will erode any gains that we've achieved in fighting infectious diseases. So those are 7 lessons and messages that I would like to make sure that you memorize as I go through that. So first of all, let's look at political leadership. How has that played out? If you look at the first slide I presented, the first cases of COVID-19 were reported in Egypt on the 15th of February, and on the 22nd of February, Chairperson Moussa Faki convened a meeting of all ministers of health in Addis Ababa in the presence of WHO. Dr. Tedros called in by Zoom. Dr. Moretti was present, and she's actually here with a green dress and the front line. And we agreed on the joint continental strategy. We looked at what was going on in the whole world and said it was incumbent for all of us to have a strategy that will be underpinned by the need to cooperate, coordinate, collaborate, and communicate. And subsequently, on the 8th of May this year, the head of states looked at what was going on in India and convened an urgent meeting of all ministers of health to agree on an adapted strategy that focused on enhanced prevention, enhanced monitoring, and enhanced treatment. That is the power of political leadership right there. The second lesson is the critical role that national public health institutes have played. Whether we're looking at Nigeria's CDC or the Mozambique National Public Health Institute or the Zambia Public Health Institute or the Ethiopian Public Health Institute, they have been at the forefront of fighting this pandemic. And that speaks to the need to continue to invest in strengthening these national and regional national public health institutions that will be critical for us in defining the trajectory of this pandemic and in preparing ourselves to fight the next pandemic. Lesson number 3, the power of regionalism. In January of 2020, actually, no country in Africa had the right reagents to test for COVID. But by February, we organized ourselves and worked closely with WHO to start trainings in Senegal. You can see on the left-hand side of the continent in blue, and then in South Africa. And by August, all countries in Africa had developed the capacity to test for COVID-19. And this picture shows you some of the hands-on training that of the workshops that we did rapidly in Senegal and in South Africa. Again, because of the efforts of the partnership with the private sector, and at this point, I would like to echo what President Kagame said about the unique contribution that Stripe Masiyiwa, together with President of the Afri-Exim Bank, Benedict Orama, and Dr. Vera Songwe of the UN Commission for Africa, all came together to establish the African Medicine Supply Platform, which is a unique stop shop, or where you can actually go in there and shop for your medical commodities to fight COVID there. It suffices to go into the amsp.africa, and it offers you that unique platform there. That is the power of regionalism, and it speaks to the fact that if we come together and coordinate ourselves, we can actually do a lot more than doing it by us individually. The second lesson in the power of regionalism is the way we've organized ourselves at 3 levels for pathogen genomics. And a pathogen genomic institute that we set up at Africa CDC was established in 2018, December 2018, in anticipation that we will probably have what we are dealing with today. And we didn't just know that 1 year later, we will be dealing with such a deadly pandemic. And this Pathogen Genomic Institute has been network has been extremely powerful in our ability to network and work with each other, including sites in Nigeria led by Professor Happy, Christian Happy, Professor Tulio in South Africa, regional centers in Morocco, Senegal, Nigeria, Ghana, and across all the continent, and national systems that have worked collaboratively. Our initial target in the middle of the year was to arrive at sequencing 50,000 genomes by the end of the year. But I'm very pleased to say that that target has been exceeded. And that through that pathogen genomic network, about close to 57,000 genomes have been actually contributed. And we now know that based on the extraordinary work that has been done in South Africa and Botswana, that we have a new variant now, and about 14 countries have now reported in Africa the presence of the Omicron variant. Lesson number 4 is really that the limited access to health security commodities there. And our head of states have been extremely hands-on in exercising their leadership through the bureau meetings, especially last year when President Cyril Ramaphosa, the president of South Africa, was the chair of the African Union. And the picture you see on the right-hand side here was taken on the 20th of August, where the head of states came together and we're discussing a strategy for vaccinating the continent. And I would just invite you to read the last sentence here, where the head of state stressed that Africa should take appropriate measures as part of the strategy to ensure that we secure timely access to COVID vaccines when they become available. In terms of that, where are we? We now know that the WHO has recommended that 70% of the population be vaccinated. And if you extrapolate that onto the continent, we need 1.8 billion doses of vaccines, which means we have to work very hard to immunize about 900 million people across the continent. The COVAX facilities, which is a global partnership, has committed to supplying us with in excess of about 26% of their needs. The AVAD, which is the African Vaccine Acquisition Testing, which is one of the great innovations during this pandemic, which was set up by President Ramaphosa and coordinated by Stripe Masiwa, has secured 400 million doses to vaccinate about 400 million Africans. We still have a gap of 13%. At this point, I would also like to recognize the extraordinary partnership and leadership of the Afri-Exim Bank, where they facilitated and made available $2 billion to support these efforts, the AVAD efforts to secure the 400 million doses of vaccines. But as of the 9th of December, the continent had been supplied with 431 million doses of vaccines, of which 244 million had been administered, and the continent had immunized 11% of its population by single dose, and about 7.3% of the population that have been fully immunized. If you compare that with the rest of the world, I mean, you see at the bottom bar here where Africa is compared to China, where they've immunized about 85% of the population, Europe about 71%, United States 71%, India about 58%. That is summing those who are fully vaccinated and those who are partially vaccinated. You heard this statement made earlier on that in order to begin to address this gap, the President Tshisekedi, the chair of the African Union, launched a partnership for African vaccine manufacturing to make sure that we address this gap. And I'm very pleased that there's been a remarkable progress since that launch. It has galvanized the continent through a partnership for African vaccine manufacturing. On October 26, you all know that BioNTech signed an MOU with the government of Rwanda and Senegal to produce mRNA vaccines. And Senegal have also developed a partnership with several European governments. Morocco has also signed agreements to start vaccine manufacturing. South Africa with BioVac, Afrigen Biologics, Aspen, and others are actually producing vaccines. That is for the Johnson & Johnson vaccines. Egypt, Algeria, and others are also lining up to producing vaccines. So again, the statement I made in the opening that I believe strongly that the way we shall fight the next pandemic in Africa will be very different from the way we are fighting this pandemic because of these developments that we are going through.
This is a building in Senegal that I was privileged to visit about 4 weeks ago with Amadou Sarr to see a huge infrastructure that the government of Senegal is putting in place at the Pasteur Institute to produce not just COVID vaccines, but for other vaccines. And we will see this kind of efforts going through across the entire continent. Also pleased to know that because of COVID-19, companies in Africa are beginning to produce locally diagnostic tests. This is a production site in Senegal where they are producing the antigen test for COVID. And we now know as of last week or 2 weeks ago that similar efforts or productions have started in South Africa. Morocco has started producing PCR diagnostics for COVID, which is a remarkable test, and you can produce the results in less than 2 hours there. In terms, lesson number 6 is respectful and action-oriented partnership. At this point, I really want to recognize the remarkable and bold partnership that Africa CDC and the MasterCard Foundation have established, which is a $1.5 billion partnership to support our efforts to vaccinate 50 million Africans and to ensure that we get to the 60 or 70% coverage there. That is a good example of what we can achieve by co-creating a vision and programmatic goals if done that in a respectful and action-oriented manner. And the last lesson here is really the effect of what pandemics can do. Very early on in this pandemic, we wrote a piece in the PlusMed where we clearly indicated that there will be severe consequences on indirect impact on existing challenges that we face on the continent. That is programs related to HIV/AIDS, TB, malaria, and immunization programs and reproductive health programs. And we now know in papers that have just been published, and this is a recent paper that was published just in April, that shows that the HIV/AIDS in an era of coronavirus is what the authors are calling juxtaposition of two pandemics. We should always remember that HIV/AIDS is still there, it's still a severe pandemic, and it's still tuberculosis is still there, and malaria is still out there. The Global Fund has actually brought this to attention and reviewed the devastation that COVID has caused on HIV, TB, and malaria programs across the continent. So on this is a call to action as I move to my conclusion that we should be mindful of the fact that as much as we have a very severe pandemic, we should not remove our eyes from the HIV, TB, and malaria challenges that we have on the continent. So where do we go from here? You've all heard from our various leaders, political leadership, the call for a new public health order that hinges on 4 things. Actually, strengthening our public health institutions, workforce, expanding manufacturing on both vaccines, diagnostics, and therapeutics, respectful, action-oriented partnership, which is all underpinned by the need to invest ourselves in supporting this. Domestic financing is so important so that we can achieve these 4 goals. And in conclusion, let me just leave you with these 3 messages: that we need to use COVID-19 as a stimulus to strengthen our health systems, invest in health institutions with a focus on local manufacturing for our own health security. Africa needs to exercise leadership and ownership so that we prepare for the next pandemic in a way that we do not struggle and scramble the way that we have scrambled in this pandemic. Thank you so much for the attention, and let's build back better, bolder, and bigger.
Thank you very much, Dr. Nkengasong, for this enlightening presentation on the status of the COVID-19 pandemic in the African continent, and for reminding us of what we need to do at home if we are going to conquer COVID-19 and other pandemics. We are moving now to the next presentation, and I'm delighted to invite Professor Moore. I'm pleased indeed that Professor Penny Moore from South Africa, South African Research Chair of Virus Host Dynamics and Reader, Associate Professor at University of the Witwatersrand and the National Institute for Communicable Diseases, will be explaining to us the role of immune profiling of vulnerability to SARS-CoV-2 in Africa. You have the floor, Professor Penny Moore. Thank you for joining us.
Thank you. Thank you for having me. And yes, I'm going to speak today about immune profiling to understand our vulnerability to SARS-CoV-2 infection in Africa. And I'm going to start by making the same point that Dr. Nkengasong has just made, which is that as we look towards vaccine distribution, current uptake of vaccines and distribution of vaccines remains highly unequal. This is a schematic from The Economist, which shows when we can expect widespread vaccination coverage to be achieved. And you can see that while areas such as the US and South America, Europe and Australia are in blue, getting already quite widespread vaccine coverage, the situation for Africa remains very, very different, with widespread vaccine coverage really only anticipated from early 2023. And I think all of the work that I'm going to be presenting really needs to be taken in the context of this uneven vaccine distribution. Of course, as you've already heard, we have the double epidemic in parts of Africa as well, and particularly in sub-Saharan Africa, where we're both unvaccinated from a COVID-19 perspective, and we bear a really substantial HIV burden. If you look at the map on the left-hand side here, this map shows you HIV prevalence amongst adults aged 15 to 49. And you can see, particularly focused on sub-Saharan Africa, that looking at my country, South Africa, we have 7.5 million South Africans who are HIV positive, and probably 2 million of these who are not virus suppressed and are therefore to some extent immunocompromised. How this links, of course, to the SARS-CoV-2 pandemic is that there is emerging data that indicates that HIV unsuppressed individuals may become long-term SARS-CoV-2 shedders. So this is data showing one such individual. This is an HIV positive person in South Africa who was unable to clear a SARS-CoV-2 infection. And when Alex Segal and his colleagues looked at what happened to that SARS-CoV-2 virus over time in this individual, you can see the mutations over time shown at the bottom of that slide, more and more mutations arising within this individual as this person was unable to clear the SARS-CoV-2 infection. And of course, this is the juxtaposition of the two epidemics that you've already heard about, is that they impact one another very substantially. As some of you may know, I'm based in South Africa and have really benefited enormously from the enormous genomic surveillance effort that has been undertaken in my country as part of the broader African effort. In South Africa, our genomic surveillance for SARS-CoV-2 has been led by the Network for Genomic Surveillance in South Africa, really spearheaded by Professor Tulia D'Oliveira, Janelle Beeman, Carolyn Williamson, and others in our country, and leveraging an existing network of laboratories that had been established as part of the National Health Laboratory Services for HIV surveillance, viral loads and CD4 counts many years ago. The network for genomic surveillance in South Africa has made really enormous contributions, I think, to understanding SARS-CoV-2 pandemic, both within South Africa, but also through extensive training and collaboration with colleagues throughout Africa. In South Africa, NGSSA has generated nearly 25,000 genomes, and that's enabled people to really understand in exquisite detail the epidemic in South Africa, which in many ways mirrors the epidemic that has occurred elsewhere across our continent. In South Africa, as elsewhere, we are now entering our fourth wave, and I'll come to that. The original D614G variant dominated our first wave, and that's shown in grey here at the bottom. That was replaced by the very neutralization-resistant Beta variant, the third wave being caused by the Delta variant, as for many other countries. But we've also been able to identify several unusual variants of immune concern. One of them, which I'm just going to mention briefly, is the C.1.2, which is a highly mutated variant that was persistent in South Africa, accounting for somewhere between 4 and 5% of our epidemic for many, many months. And we watched that with interest from an immune perspective. And then, of course, in the last few weeks, we, and like all of you, have watched as the Omicron variant emerged in South Africa, detected by our colleagues here in South Africa and in Botswana very early on, and that data shared incredibly rapidly with the world. The role of our lab in immune profiling really began with the emergence of the Beta variant. The history of our lab is, in fact, HIV. We've, for 20 years, studied the interaction between HIV and antibodies in people infected with HIV. And so as Beta emerged and clearly showed the potential for immune evasion, we redeployed all of the platforms and collaborations that we'd established over the last 20 years for HIV work and quickly pivoted to SARS-CoV-2 to try to contribute to the immune characterization of these new variants. I'm showing here the timeline because I think it provides a model for how science now works in SARS-CoV-2 characterization and new variants. But for us, it was paradigm shifting, and it relied extensively on wonderful collaborations that we had had for many years, highlighting particularly Nicole Dory-Rose and David Montefiore at the VRC and at Duke, but with many collaborators across the world. And we rapidly went from the identification in December 2020 of mutations defining beta to structural modeling, which quickly indicated that we were looking at a variant with immune evasion potential. That data was rapidly generated and presented to the local leadership and then more globally. And the preprint was online by the 20th of January. And as I say, I think this now provides a model for how quickly we've all had to learn to work to understand the potential for emerging variants to wreak havoc. We spent a significant amount of time defining escape from and immune responses to the new variant, and we're amongst the first to show that the beta variant was resistant to antibodies. We've also worked very hard to understand the impact of mutations in the beta variant on the efficacy of vaccine responses, here looking at AstraZeneca and the Johnson & Johnson vaccines, but we've looked at the other vaccines. And this has provided the basis for our subsequent work for looking at other variants. I mentioned this extremely highly mutated variant C.1.2, which is shown on this phylogenetic tree. As you look at these phylogenetic trees, the further you move from the center, the more evolved the variant is. And you can see that at the time, of course, this has now changed, but at the time, C.1.2 was the most mutated variant that had been identified. And this rapid accumulation of mutations probably represents an evolutionary head start that the virus had within one of these individuals who's unable to clear SARS-CoV-2 infection. We were able to show again for this C.1.2 variant that here's shown here in purple at the bottom here, that this variant had alarming ability to evade antibody responses, again from, in this case, AstraZeneca and the Johnson & Johnson vaccines, but also from convalescent plasma. And we watched this and wondered whether this might account for the fourth wave that we knew was coming in South Africa. The other concern we had from an immune evasion point of view was that there was considerable evolution within Delta. Delta was, as you all know, responsible for the third wave, but Delta is not one single variant. As we studied the huge number of Delta infections occurring globally, we realized that even within Delta, we were seeing emerging sublineages, what are called the AY sublineages. And essentially, each one of these multiple rainbow colors here represents a different version of Delta. The pie charts on this map of the world indicate the different AY versions located across the globe. And the larger the pie chart, the more sequencing is occurring. So for example, if you look at Europe, you can see a substantial amount of sequencing and most of them representing the ancestral Delta or AY4. However, if you look within Africa, which is relatively under-sequenced despite the mammoth efforts by many of my colleagues, but is relatively under-sequenced. But if you look at the amount of variation that was occurring within Delta across the African continent, you can see from this pie chart, huge amount of variation occurring within Delta across the African continent. So despite low sequencing coverage relative to many of the other regions of the world, substantial diversity. And many of us anticipated that this would be the start of the fourth wave in South Africa. However, as you, I'm sure, are all aware now, that was incorrect. And it does appear that the fourth wave in South Africa is as a result of the emergence of the Omicron or B.1.1.521 variant, now designated a variant of concern by the World Health Organization. This was the most, and it is the most divergent variant that we've seen to date. This is now the red lines, which have gone even further away from the center of this tree. The Omicron variant has 45 to 52 amino acid changes across the entire genome. And almost all of these, somewhere between 20 and 32, are located within the spike protein, which has huge implications, as you can imagine, for vaccines. And the majority of Omicron, but not all, but the majority of Omicron sequences also contain this deletion at position 69 to 70, which results in S gene target failure. And essentially that means that something we saw with the emergence of the Alpha variant in the first wave, it provided us with an alternative strategy for tracking Omicron as it spread across the world that did not rely on the rather relatively slow genomic sequencing. Omicron is, of course, substantially spread. This map has to be updated almost on an hourly basis now and is probably already out of date because it's about 2 hours old. But 2 hours ago, Omicron had been detected in 65 countries across the world. More than 3,500 sequences had been generated. And if you look at this schematic down here at the bottom, Omicron in red now accounts for 10% of new infections globally. So certainly has spread widely, and we're certainly seeing many examples of community transmission of Omicron. This is a visual representation from colleagues in the UK, and I think it best captures the huge level of diversity within Omicron compared to Delta in the middle and Beta on the far right-hand side. And essentially, each one of these little lines of text here represents a mutation in Omicron. And you can see that there are many, many of these mutations that are spread across the spike protein. So obvious concern from an immune profiling perspective. In this slide, I'm drilling down into more detail to look at the specific mutations within spike, and the reason that just when we looked at these sequences as they emerged in Botswana and South Africa, we knew we were dealing with a variant that had huge capacity to evade immunity. This is a different version of the spike on the far right-hand side here, and each one of these red dots indicates a mutation that defines Omicron. And you can see they're clustered largely within the receptor binding domain in yellow and the N-terminal domain in cyan. But also some alarming mutations here in the S1, S2 region, very, very characteristic of immune escape. This shows you the precise mutations that define Omicron up at the top here in red. There are many of them, as I've pointed out. There is diversity within Omicron, and this is something I think we're only just beginning to get a handle on as more and more sequences come out, but not all Omicrons are identical. In light pink here are mutations that are present in some, but not all Omicron sequences. Some of these are old familiar faces. For example, here at position 484, we see mutations and mutations here at 144. And many of them are mutations at sites that we've previously seen in other variants of interest or variants of concern or in C.1.2, as you can see when you scroll down the columns that define each of these. But you can see that there's many, many new mutations in Omicron that are not present in any of the previously defined variants. Look down here. Bottom, you'll see that I showed the mutations depending on what is known about them. In blue, particularly these ones within the RBD and the N-terminal domain, are those that we know have an immune evasion contribution. In green are mutations such as at position 501, 614, 655, 679, 681 here that we know are associated with increased transmissibility. But I think most concerning is the number of mutations highlighted in red. These are simply mutations we know nothing about, and so a lot of work has to be done. And then just to point out that Omicron also contains mutations within the nuclear capsid that are known to increase infectivity. So the sequence indicated a combination of increased transmissibility and increased immune evasion, and I think that's what's panning out. This is some of our early data showing that Omicron does indeed exhibit substantial immune escape from antibodies. This is comparing here 614G, the ancestral variant in South Africa, with Beta and with Omicron, looking on the left-hand side at individuals vaccinated twice with the Pfizer vaccine, and on the right-hand side, individuals vaccinated with the Johnson & Johnson vaccine. These GMT or geometric mean titers are a measure of how sensitive the virus is to antibodies. So, for example, the D614G variant here has very high titers, good neutralization, more than 1 in 1,400. But if you look at neutralization of Beta, it was reduced, as we know, and it's further reduced against Omicron from 1,400 down to 1 in 80. The situation is even more alarming, I think, for the Johnson & Johnson vaccines here, where the titer has been reduced from an average titer for all of these individuals of 1 in 300 to no detectable neutralization in our assays. So a variable but substantial drop in neutralization against Omicron in these vaccinee sera, and we're working to expand the numbers here and to look at convalescent plasma as well. I've highlighted down here at the bottom several other studies that have emerged at the same time that show pseudovirus neutralization data. But this is also consistent with data from my very close colleague, Alex Segal, who performed a live virus neutralization assay, and also shows a substantial drop when you compare D614G with a average titer of 1,300 to Omicron, where the titer has dropped in this case somewhere between 20 and 40-fold, this data being 40-fold, to a titer of 1 in 32. This is for individuals in orange who are vaccinated with Pfizer, and then in green, individuals who are then vaccinated and infected, so very high neutralizing antibodies. And while you can see that in many cases there's a substantial drop, the people who started very high do maintain some activity against Omicron. So where you start, how good your antibodies are is a very good indicator of how well you'll be able to neutralize Omicron. I think the emerging, and literally again by the hour, the emerging data suggests that these reduced antibody titers against Omicron are likely to result in decreased ability of vaccines to prevent infection. But we need to differentiate that from our understanding of the ability of vaccines to prevent severe disease by Omicron. There is not yet any T-cell data. Many in silico analyses have been performed, And these do indicate that the T-cell epitopes are likely to be retained, and therefore vaccines are likely to retain substantial activity against severe disease. But this is very early on, and we need the data to come out. And that's where I'll end. I hope I've made the argument that real-time phenotypic assessment of emerging variants in Africa is essential, particularly in the continuing context of under-vaccination and in some places high levels of HIV. In our lab, and I think in many others, the rapid pivot to SARS-CoV-2 is only enabled by very strong existing collaborations and platforms and technologies, most of which have been developed over 20 years, in our case, working in the HIV vaccine space. And the global spread of Omicron, which is extremely antibody resistant and appears to be highly transmissible, and I suspect Slim will speak much more about this in the talk that follows mine, further highlights the role of rapidly linking genomic surveillance to immune profiling. I want to again acknowledge the Network for Genomic Surveillance in South Africa, and the leaders of this very large network are shown on the slide, but it's been astonishing to watch this group and how they've collaborated nationally, internationally, regionally across the world. They're a wonderful group of scientists. I also want to acknowledge a relatively new collaboration, the Global Immunology and Immune Sequencing for Epidemic Preparedness. This is the GEISER network, a new network which includes many of my African colleagues, and I'm looking very much forward to working more with this group of people. GEISER extends all the way from pathogen sequencing, from links to the sequences through to mAb discovery, diagnostics, understanding therapeutics, and assessing vaccine and convalescent plasma, with a really substantial emphasis on rapid sharing of reagents and of data. And then to acknowledge my lab here in Johannesburg in South Africa, who is shown here, and who've worked incredibly hard over the last many months now to generate a huge amount of data on variants and to do a lot of immune profiling that has been valuable for all of us. And then I'd like to thank my funders, and I'll stop there.
Thank you so much, Professor Moore, for that excellent review of the ton of work that has gone into rapidly characterizing this evolving virus. I'll note that we're running a little behind on time. We'll borrow some time from the panel discussion at the end. But at this point, I'm very pleased to welcome Professor Salim Abdul Karim, Director of the Center for the AIDS Program of Research in South Africa, or CPHIA, who will discuss the new syndemic of COVID-19, HIV/AIDS, and tuberculosis in Africa. Professor Karim, the floor is yours.
Thank you very much, Trevor. It's a great pleasure to be here. So at the last minute, I thought that it would be of greater interest to the audience to hear about what is it we do and don't know about the Omicron variant. So the latest version of the program has this as my title. For those who are still interested in knowing about how HIV and COVID-19 and how these two pandemics collide, I've already given that talk, and a taped version is available for you to watch it. So today, you're going to be hearing about Omicron. And I'm so pleased to be able to do this because in so many ways, what Professor John Kingersong and Professor Penny Moore have done is lay the groundwork for what I have to say. So what is it we do and don't know about Omicron? So the first is, why the concern about new variants? Well, variants have changed the COVID-19 endgame. So, we really need to have a better understanding with each new variant. What are their clinical implications? What are their public health implications? What are their vaccine implications? So this idea originally in November last year, we have an infectious disease, we have a vaccine, so all we need to do is vaccinate people and then we can go on our merry way. Well, variants have put paid to that idea of an endgame. And so as they've influenced how we think about the way in which this pandemic is going to progress and its endgame, we're understanding the importance that we need to have better understanding of correlates of protection so that we can estimate very quickly what our vaccines are going to do against each new variant. But we've seen the impact of variants. We've seen the challenges that they bring to us. And here I'm sharing with you the first wave in India, Brazil, and South Africa. You can actually see India here had quite a modest first wave. In fact, politicians in India were saying, they've conquered this virus. Well, variants changed that situation. You saw in India the way the Delta variant caused quite a terrible second wave, horrific pictures we watched on our television screens. The Gamma variant caused a terrible second wave in Brazil. And in South Africa, the Beta variant caused the second wave, and the Delta variant caused the third wave. So what we are seeing is that variants are associated, not always, but usually, with a resurgence of infections. And so we've seen over time that we've had 5 variants of concern that have emerged from 4 different continents. Now, as you've heard from Dr. Moore, it's really, we think, immunosuppressed individuals and possibly transmission through intermediate hosts like animals. Those are really the 2 most clearly hypothesized mechanisms by which variants of concern emerge. And of course, immunosuppressed individuals that can maintain persistent infection for a long time occur all over the world. And you heard of cancer and all kinds of other causes, including HIV and hereditary immunosuppression. So you've got a whole range of reasons why people are immunocompromised across the globe, across all our continents. And so we've been seeing variants emerge across the world. Now, in South Africa, just about 2.5, 3 weeks ago, we started seeing a small increase in numbers, and it coincided with what we observed, that in our first wave, which was driven by D614G, and then our Beta variant, and we saw how when Delta came along, literally it displaced the Beta variant. We still see just a handful of Beta cases, but it's really been to a large extent, been, pushed out of town. You want to think about it, Delta is the new sheriff, and it's running the old guys out of town, and here comes Omicron. So if Omicron has the level of transmissibility we think, we can expect it to give Delta a bit of the same treatment that Delta gave Beta. Now, the way this works is that the individual viruses are still transmitting, but because they are so slow compared to the new virus, the new virus overtakes and infects many individuals, or the previous viruses can get to them. So that's how it becomes dominant. Now, you've already seen, and mine is a bit dated now, the way in which Omicron has spread across the world, and the darker orange shows you where there is local transmission. So it's no longer an issue of transmission by travelers. In most countries, you now have local transmission of Omicron. So let's look at the Omicron mutations. Penny has covered this, so I'll cover this very briefly, but I'm going to focus on, so what do the early data tell us? There are 3 key questions we want answered. Is it more transmissible? Is it more severe? Does it cause more immune escape? Well, when we look at the multiple mutations that we see in Omicron, it's quite striking that it has mutations that are also present in the Alpha variant, the Beta, Gamma, and the Delta variant. We've seen, for example, how it has mutations at positions 417, 484, 501 that are common to the Beta variant, that are associated in the Beta variant with some level of immune escape and transmissibility. So Omicron, in many ways, has many of the mutations that confer individual advantages to the previous 4 variants of concern. So based on what we know about those mutations,